Advancing the airway. Should we be advancing the airway? This is becoming more and more of an interesting question in EMS for multiple reasons. And I know that I'm here to help you guys pass National Registry or maybe paramedic school for some of you. But advancing the airway is becoming a task that is being removed from a lot of fire departments, a lot of EMS agencies. And I'm not going to say it's not for a good reason, because I think it is. We don't, A, probably do it enough. B, we don't train on it enough. And I think some people die because of advancing an airway, and I'll explain myself. And the first thing that I want to bring up on advancing the airway is, what's the benefit of advancing an airway? When you think about you intubating somebody, I mean, why can't I just bag them, right? If all that talk that we just did on expanding the alveoli and allowing for diffusion to happen by just me bagging, why can't I just do that shit? And I'll just take them to the hospital, right? The whole reason why you're going to intubate somebody is, for one, to reduce the chance of aspiration. Okay, if my patient vomits, will their airway be protected if I'm just bagging them? No, of course not. But if I have a tube in place, it will protect them. It will protect their airway. Number two, reducing the chance of gastric distension. Okay, common test question. Reducing the chance of gastric distension. Now, once you bag somebody, especially some of you heavy hands that are squeezing the shit out of that bag, you're going to cause a lot of that air to get into the stomach. Okay, when you cause air to get into the stomach, we increase the air that's inside of the stomach. And here, this is the problem with increasing air in the stomach. One, we increase the chance of them throwing up, right? Two, you actually make that stomach get bigger and bigger and bigger, and it actually starts to impede on tidal volume of your lungs. So your stomach starts to inflate, and it doesn't allow your lungs to fully expand. So gastric distension is problematic. Those are two of the major reasons why we want to intubate, okay, or we want to have an advanced airway in place. Now, maximum number of attempts and maximum amount of time is an interesting question. What do you guys think? Should we have a maximum number of attempts? Should we limit it to 1 intubation attempt? Should we limit it to 2 intubation attempts? 3? Should it be 3 different providers that intubate? It's a weird question. I promise you, you're going to get on that call one day and you're going to see 6 different dudes trying to intubate the same patient. They butcher the shit out of the airway and the patient could potentially die. Palermo says, might irritate the airway more and swell, and hypoxia comes into play when no ventilation. Yeah, whoa, man, that's a whole different conversation. Should we be ventilating in between attempts? Absolutely. Now, I appreciate you bringing that up, because I didn't even talk about pre-oxygenation. Pre-oxygenation, by definition, for the national, is you're breathing for this patient, or you're ventilating, you're providing oxygenation to the patient for 2 to 3 minutes prior to intubation. 2 to 3 minutes prior to intubation, we're oxygenating the patient. When it comes to number of attempts, to be honest with you, that's a protocol thing. Unfortunately, there's nothing in national standard that says, hey, you get 2 attempts only. But you want to know what the national does say is that it should be limited to 30 seconds for an attempt, right? 30 seconds. And that is a standard. So understand, you must be able to intubate within 30 seconds. If you are unsuccessful at intubating within 30 seconds, you as a provider have to stop and reoxygenate the patient, okay? Something to think about. An easy test question you get out of that, and also real-life application. Are there any negative effects to intubation? We already talked about hypoxia. Palermo just brought it up. Says, hey man, while we're attempting to intubate, no one's breathing for the guy or the girl. And because of that, they become hypoxic. Another one is stimulation of the vagus nerve. Talking about stimulation of the vagus nerve, what do you think that's going to cause during an intubation attempt? If we stimulate the vagus nerve too much while attempting to intubate, we're going to cause bradycardia, and we're going to cause hypotension. Could be a result of intubation. I've seen this test question worded many different ways on trying to determine, hey man, what's going to happen if I start attempting an intubation? What's going to happen to my patient's heart rate? What could happen to my patient's blood pressure? Understand that that is a possibility. How about right main stem? If I intubate somebody and I push my tube too far, there is a chance that I can go into one lung. Okay. I'm not in both lungs. So, and if I'm not in both lungs and I'm oxygenating the patient, my patient's only being oxygenated half of what they should be. Dangerous. Okay. This is why we'll talk a little bit about checking your tube and making sure that we're in a good position, good placement. We need to check, but that is another problem with intubation. How about using the teeth as a fulcrum? Breaking teeth is a huge problem with intubation. So there's a lot of negative effects that can happen with intubation. It needs to be done correctly and it needs to be practiced often.